specifically for EM folks. So, I think this is critically important. I don't think we think about this very much in the line of work that we do, but when we're talking about sort of having palliative type conversations, having conversations with our patients, when they present with these critical illnesses, intracranial hemorrhage, huge ischemic strokes, cardiac arrest, we sort of need to set the scene about what's going to happen in the next few days, next few weeks, what's going to end up happening with these patients. So prognostication is really important for that. So we're going to go through this. So our objectives are to sort of talk about why prognostication is important relative in the ED, to discuss prognostic rules as they pertain to intracranial hemorrhage, ischemic strokes, and cardiac arrest, and to discuss how to translate this prognostic information to the care that you provide in the ED. Okay? So prognostication is the prediction of future medical outcomes of a treatment or disease course based on medical knowledge. So I think we're really good at the diagnosis part, right? We're really good at the treatment portion. We can really sort of narrow down our symptoms, try and figure out what the patient has, and then treat them quickly, right? The prognostication bit, I think we're good at prognosticating in the few days, in the next few hours, in the next few days. We can tell, you're not really responding well to the treatment. Maybe you should stay in the hospital. You don't look so good. I think you should stay for a couple days, or you need to be in the ICU, or you can go home. You look great. So, right, short-term prognostication we're pretty good at. Long-term prognostication we're not so good at. Right? We just don't have the experience. We see our patients for a couple hours at most. We don't really know what happens to them when they go upstairs, when they get transferred, etc. So this is, this is always really interesting to me. This is why I always follow up on my patients, because we just don't know. So we don't develop that clinical experience a lot of the times in terms of what happens with our patients. We just don't know. So this is typically what happens when we prognosticate, when we develop the experience and we see enough patients. We gather information, we gather the findings, we develop the diagnosis, we see how they respond to therapy, we develop a general sense of prognosis, and then we can apply this to specific patients, right? We have specific findings for a specific patient, psychosocial factors, and then we develop, that applies to a specific patient. So Gestalt is, what's happened for many years in the past. So clinicians develop experience, they develop Gestalt about how a patient's going to do with certain treatments. The advantages of that are that it's flexible. You have, you sort of know immediately, you can speak to your patients directly about what you think may happen, how you think they're going to respond. There's ease of communication. It may not always be so accurate when you're doing it that way. There's that gut feeling, but it's not always evidence-based. It's maybe just based on some biases that you've had. You've had some patients that stand out in your mind, and that's how you develop your sense about what's going to happen with them. As opposed to validated models, where there's greater accuracy, there's some research there, there's some evidence to support what you're going to be telling your patients. So in terms of decision making about next steps, right? So these patients present with these critical illnesses when they come to see us in the ED. How do we make decisions about next steps, goals of care? So this is direct quote, dependent on provision of adequate information concerning outcomes, because this data influences patient preferences, making accurate data imperative, right? So they need to know what the chances are of survival, how people have done in the past, what is the data behind the intervention and the outcome. But at the same time, the science and the data is not the whole picture. Obviously, it's a multifaceted decision. There's many components. There's patients' values, patients' feelings about these interventions, about how to move forward. So it's a difficult decision, but the science and the data needs to be there when you talk to these patients about next steps and going forward. Okay. So prognostic scales, there's many scales, right? Almost for every disease. CHF scales, the Seattle Heart Failure Model, dementia scales to predict mortality, to predict function. There's cancer scales, mostly based on performance status. There's palliative scales, palliative prognostic index, palliative prognostic scores that help us to determine, again, mortality, function, etc. All right, so in terms of intracerebral hemorrhage, so we know these numbers, right? It's about 15% of strokes. Worldwide incidence did not decrease between 1980 and 2006. Median case fatality for intracerebral hemorrhage is 40% at 30 days. And there's no intervention of proven benefit in improving outcomes. Bad, right? When we see it a good amount, and we just don't, I don't ever know really what happens to these patients, because oftentimes we transfer them out, we don't know what ends up happening to them down the road. So there's prediction tools. There's several. My goal is to find some tools that we could use, that we could apply in the ED to help us make some decisions about going forward. So the intracranial hemorrhage score. It was created at UCSF. It was a retrospective chart review, 152 non-traumatic intracranial hemorrhage patients. 30-day mortality was about 45%. 5 independent predictors of 30-day mortality were GCS score, intracranial hemorrhage volume, intraventricular hemorrhage, infratentorial location, and age. So this is the score. All right, so on your left, you see the components of the score. The GCS is categorized, and points are allocated to each category. The volume of the intracranial hemorrhage, this is based on ABC divided by 2, right? A being, you guys are familiar, A being the largest diameter, B is perpendicular, C is the number of slices divided by 2 to estimate volume. Intraventricular hemorrhage also gives it a point, infratentorial location, and then age, greater than 80, you get 1 point. And it's been shown that at 30 days, a score of 1 correlates to 13% mortality. A score of 5 correlates to 100% mortality. There were no patients in the cohort that had a score of 6, but as you imagine, I don't think they did so well. So this helps us to give us an idea. I thought this was incredibly interesting, just to figure out how these patients do, and to give us a sense of how they will do in the next 30 days. Any questions? Any thoughts? Okay, so survival is one part of the conversation, right? But there's also sort of the ability and the function. How are these patients going to do? They may live, but are they going to be functional? Are they going to be able to go home? Are they going to be nursing home bound? So predicting functional status, and I wanted to actually ask Dr. Lott how she uses these scores, or if she uses these scores. But the FUNC score is what I came across. It's an 11-point clinical grading scale, and it helps us to determine who's going to attain functional independence. It was done with 629 patients, and what they did is they used the Glasgow outcome scale as determined at 90 days. So a functional independence was defined as a Glasgow outcome scale greater than 4. So moderate disability, where they're able to live by themselves, or mild disability, where they're able to actually go back to work and school. So 345 out of 629, or 55%, survived to 90 days, and 162 people achieved functional independence. And the score that they derived from this analysis was based again on intracranial volume, here on the left, age, location, GCS, and then the pre-ICH cognitive impairment. So that's all, the piece that's going to be a little bit hard to attain in the ED. This was based on a previously validated score. They asked family members about what their cognitive impairments were like at home. But you can sort of get a sense of what their functional status is like. If they come from a nursing home, maybe not so good. If they're from home, maybe a little bit better. And so they came up with these scores. On the x-axis are your categories of the FUNC score, and on the y-axis is the percent that ends up being functionally independent at 90 days. So a score of 11 gives you about 100% chance of being functionally independent at 90 days, okay? So I think this is incredibly useful from, in what I do, and again, I sort of am able to sit down with these patients when I work upstairs and really have a conversation about next steps. So based on this information, it makes it a lot easier for me to really talk about where we're going, how this is going to impact your life. But I think in the ED, it's also really pertinent. You're sort of interacting with these patients, but you are the first people that are really going to encounter them. So giving them a sense, you always get that question, Doc, what's going to happen? Doc, how's mom going to do? So you can give them a little bit of an approximation, an estimate, and really sort of start that conversation about, I think, we're not sure. They might do really well. Or I'm really actually pretty worried about your mom. She might not do so well. I think we take each day by day. I think we have some information to gather, but she might not be doing so well. All right, so that's intracerebral hemorrhage. So in terms of the ischemic CVA, huge impact, right? In the U.S., 696,000 cases of acute stroke in the U.S. Stroke is the 5th leading cause of death. And a really huge cause of debility in the U.S. So when I was looking for prognostic information in terms of ischemic strokes, age and NIH stroke severity scales were sort of very predictive of how these patients were going to do. When I looked for specific things that really predict outcomes, there's actually a lot of really interesting stuff that's out there. Prolonged QTC is a predictor of mortality in acute ischemic stroke. BNP as a predictor of functional outcomes in ischemic stroke. Plasma level, peptin levels. So this is all really very beginning stages of research, but sort of interesting. When I look specifically for prediction rules, again, stroke severity, age, time to treatment, as Dr. Law really sort of emphasized, really big impact on how these patients are going to do. I did come across the Thrive score. So the Thrive score was initially created to predict outcomes receiving endovascular intervention, but it ended up being validated in various populations, various cohorts. So those patients, those ischemic stroke patients receiving no intervention, as well as those that are post-TPA, has been validated. And it's really easy for us to use in the ED, so stroke severity scale, age, and history. Hypertension, diabetes, and AFib. Score goes from 0 to 9, with 9, obviously 9 being worse. Score 0 predicts 79 to 88% chance of good neurologic outcomes. So good neurologic outcome being defined as on the Rankin score, 0 to 2, and I'll show you that score. And 0 to 2% of predicted mortality at 90 days. A score of 9 predicts 7 to 16 chance of good neurologic outcome and about 60% mortality at 90 days. And this can be used to predict hemorrhagic conversion after TPA. So the risk of hemorrhagic conversion increases proportionally for each additional point. Have you come across this score?
First time.
First time, but they're all in MD Calc except for Funk. We're just
Right.
ICH score.
Yeah. So I think it's helpful just for us to sort of get a sense of what's going on with our patients. So the modified Rankin score is a measure of disability dependence in the setting of post-stroke or neurological disease. 0 is no symptoms, 1 is significant disability, 2 is slight disability. So a good outcome is 0 to 2. Okay, and again, strongly predicts clinical outcomes, mortality, and risk of intracranial hemorrhage post-TPA. So really interesting. Any questions, comments? Helpful, right? We'll talk about how to really use this information, but again, to sort of give us a sense of how sick our patients are, I think these scores are good. So we're going to talk about cardiac arrest, not because it's a neurologic disease, but it does have neurologic sequelae, right? So we want to know about neurologic outcomes. To me, that's the most important thing with these cardiac arrest patients. I don't know if their brain survived the cardiac arrest. I have slew of bad cardiac arrests recently. So, I always wonder how they do. So maybe their cardiovascular function, gain cardiovascular function, but their neurologic function is always the concern, right? So I divided this into in-hospital cardiac arrest and out-of-hospital cardiac arrest. In-hospital cardiac arrest, we generally do a little bit better. 15% survival to discharge. And the issues with prognostication, as you can imagine, are that it covers a wide range of pathology. There's no really good way to validate, the various disease pathologies, the various definitions. So doing studies on this particular subset of patients is very difficult. But 44% had returned spontaneous circulation in this one study. So what happens is there's very large registries that are developed with, patient information is submitted to these registries and we sort of analyze the data. That's how most of the information comes about. 17% survived a hospital discharge. In terms of neurologic outcome, greater than 30% of survivors were discharged to nursing home or rehab facilities, whereas prior to the arrest, about 6% started from there. And of those reported, 86% of patients with a cerebral performance category of 1, which we'll talk about as well, is sort of an assessment of their neurologic status, at the time of admission actually had a CPC of 1 at the time of discharge. So sort of makes you wonder if they have good functional status prior to their arrest. Is that a prognostic indicator of doing better after their arrest? So the CPC scale is widely used in research and quality assurance in terms of cardiac arrest research. CPC-1 is good cerebral performance, they're conscious, alert, able to work, might have mild neurologic or psychological deficits. CPC-2 is moderate disability, conscious, sufficient cerebral function for independent activities of daily life. Able to work in a sheltered environment. So CPC-1 and 2 is generally considered a good functional outcome. So out-of-hospital cardiac arrest, which is more interesting for the work that we do, right? Out-of-hospital cardiac arrest. 359,000 in 2013, and survival to hospital discharge in 2013 was about 9.5%. I was talking to Dr. D'Souza about this. This is pretty typical. On average, at best, is about 10%. So again, sort of going through one of these registries of data, the CARES registry, which analyzed out-of-hospital cardiac arrest, non-traumatic in the year of 2013, 35,000 arrests, 10% survival hospital discharge. This was really interesting to me. The majority of patients, 82% who survived to discharge, had a CPC score of 1 to 2, which I thought was crazy high. Talking to Dr. D'Souza about it, he thinks that probably in this particular subset of patients, there's more VFib, VTAC arrests, which we know do better, and there's probably more bystander CPR that's initiated, or we're postulating that's probably one of the reasons, right? So, just to sort of support what we're just saying, VFib, VTAC, or some shockable rhythm, they end up doing much better. Their CPC scores 70%, and as we look at asystole, PEA, they end up not doing so well. So I found a study that confirms that there's survival benefit associated with an arrest witnessed by bystander, an arrest witnessed by EMS, provision of bystander CPR before EMS arrival, presenting with a shockable rhythm, so VFib or VTAC, in patients with rust in the field. I think in our particular population, we don't see VFib, VTAC as much. We see a lot more PEA, asystole. Our patients are sick, right? So I think our survival numbers are not quite what these registries represent. So predicting neurologic recovery in the setting of cardiac arrest. So all the data shows that really you shouldn't be evaluating for neurologic recovery until 72 hours post-ROS. Right? So this isn't really in our realm but something you can tell your patients, right? We don't know, it's really uncertain, we need to take this day by day, but at 72 hours, we'll have better information, we'll know a little bit more. And predictors of poor neurologic function, this is more for my work than what you guys are going to be seeing, but bilateral absence of pupillary reflexes more than 24 hours after Ross, absence of corneal reflexes, absence of non-sensory evoked potentials, those are all predictors of poor neurologic function. And then cardiac arrest and cancer. So this is also really interesting to me because I think, you know, I sort of have a very visceral reaction when we're coding or really seeing a really sick cancer patient. So I wanted to look at the data in terms of this population. So when they have local cancer, survival to hospital discharge is about 9%. Metastatic disease, it's 5.6%. But interestingly, prior to 1990, in the setting of metastatic disease, success rate was about 0%. And after 1990 was the first recorded successful resuscitation in the setting of metastatic disease, and the rate came up to 7.8%, which, you know, made everyone sort of wonder what was going on. And I think it's because the rates of DNR orders increased in that specific population, so they fell out of, they were not included in these numbers, so the rates went up. Successful resuscitation on the wards is actually higher than that in ICU, which I thought was surprising at first, but then if you think about it, those patients are just much sicker, right, once they get to the ICU. So